Okay, so I thank you, Venu, very much for mentioning what you did, and thank you, VJ, for happening. And I want you to everybody know that I'm very committed as the incoming president to really take this collaboration to a new level. I feel very, very strongly in this. I think that surgeons working with non-surgeons and going back and forth is really the most critical way for all of us to become successful and to take care of our patients. So these are my disclosures, none of which will have any impact on what I'm about to say today. So I think when I start off, my question is, why is deformity correction important in patients with diabetes? And I try and keep it very, very simplistic for myself. And the reason is that if we have a deformity, that leads to an ulcer, which can lead to an infection, and obviously can lead to an amputation, because we know that all infections in diabetic foot patients really begin with a pre-existing wound. So I think that we have to think about either correcting deformity or preventing deformity if we want to shift this from the right to the left. And we're all about preventing amputations. But to do that, we really have to start at the very, very beginning and recognize deformity as so important in this basic pathway. So one of the simple things I like to think about is we often hear the term plantigrade foot. And the way that I look at this is a plantigrade foot is when you walk on skin that was meant to bear weight. As you can see, I've drawn a picture there on your right. Under the metatarsal heads, we bear weight. Under the heel, we bear weight. But on the foot, which would be the left, but on our right, you can see I've written no. We're not meant to bear weight on the arch of the skin. And so when the arch collapses and people bear weight on that skin, it breaks down. We're not meant to bear weight on the side of the foot, either the medial or the lateral. And so we have to keep this in mind. And this is an example of one of my patients that I treated. And you can see looking from the back, his left foot is aligned well, but look at his right foot and ankle. He's bearing weight on his distal fibula. So that is not skin that's meant to bear weight. And ultimately, that's going to break down, lead to an ulcer, lead to an infection, and potentially lead to an amputation. So a very simplistic approach for me is if people are walking on skin that they shouldn't walk on, that's going to be a problem in our patients with neuropathy. And you can see that example right there, bearing weight. So there are many types of deformities that we deal with in diabetes, and this is not all inclusive, but we deal with Charcot deformities. We'll deal with people with a contracture of their ankle, what we call equinus, where they're plantar flexed and they can't dorsiflex as much. Some people have an equinovarus deformity where their foot is down and inward, somewhat of a club foot, if you will. There are people that have hammer toes, and so shoes will rub on the top of the hammer toes. There are people that have a stiff, big toe, get hallux rigidus, and they get ulcers underneath their hallux interphalangeal joint. Metatarsalgia is very common in people with hammer toe deformities because the metatarsal heads become prominent. But one of the good things that we've seen now is we're reducing the rate of major amputations, but the rate of minor amputations is increasing. So we're seeing post-amputation deformities, as I can show you here. And here's a gentleman that you look at the bottom of his foot, and he has a wound that's had some bioengineered tissue placed on it. But if you look at his foot, he's lost the middle 3 toes, and he's walking on skin that he shouldn't be walking on. So these types of deformities are sometimes challenging to treat. And you can see the shininess to his skin. So obviously he has some vascular impairment. So the deformities that we see are very varied, but I think we have to recognize those because it's one thing to get a wound healed, but we also want to make sure that it doesn't recur. And to prevent recurrence, we have to treat associated deformity. And that's where we as surgeons, working with our non-surgeons, and our non-surgeons to include therapists, podorthists, people who make shoes, are really, really critical. And so when I think of Charcot, I imagine, God, in a nice world, what if it was only a uniplanar deformity? Wouldn't that be great? But this is, a patient that I'm seeing. So you're looking at the foot from the front, and you can see that his foot is turned sideways. That's a supinated foot. The medial column of the foot's not even touching the ground. Look at the lateral, the front part of the foot's not touching the ground. All the weight's being borne towards the back of the foot. And that results in a patient who has a significant wound here. And so this is a very complicated thing to treat. It's not like one simple procedure, in one plane can do it. So you have to think of this as a multiplanar deformity to correct this. And I can assure you that you could probably get this wound to heal in a total contact cast, but the question is, how long will it stay healed? Because this patient's going to walk on it, and that's a very difficult thing to brace. So from a basic standpoint, as an orthopedic surgeon and a foot and ankle surgeon, I start to think of deformities. And we look on the left, the frontal plane, that's kind of looking at an AP-PA radiograph. And then your sagittal plane is looking at our lateral radiograph. But one of the more important things in orthopedics and foot and ankle surgery that we deal with is what we call this transverse plane or the axial plane, where you can have internal and external rotation. You can have abduction or adduction. And so when you look at it in the foot and ankle, it's actually more complex than above the foot and ankle because we weight bear. And this just kind of reinforces it that we're dealing with multi-plane deformities. We have that coronal plane where you look at a patient, are they in varus or valgus? You look at the sagittal plane, are they in equinus or calcaneus? And then that axial transverse plane to me is the most challenging because the foot can rotate in supination or pronation. And so I'm just going to show you a picture, but when somebody has a supinated foot, by definition, that's multiplanar. Same thing with a pronated foot. So look at this picture, which is, I think, a really good illustration. If you look at optimal alignment of somebody on the left, you can see where they bear weight, the red areas. They bear it on the metatarsal heads, to a small degree on the toes, but also the heel. But once you start supinating your foot, as you see in the center, they start to bear weight on the lateral column of the foot. That's a real problem in patients with diabetes who have neuropathy. We see this time and time again for a number of reasons. We can see it in a Charcot, but we can also see it in a patient who's had a fifth ray resection where the base of the fifth metatarsal is taken and they no longer have the peroneus brevis. And then you see on the pronation where they really collapse their arch, and now they're bearing weight on the skin of the arch, which they're not meant to bear. So we have to keep all these biomechanics in mind as we think about distributing plantar pressure. I think in my own experience that rotational deformities are the most challenging. It's easy to treat a sagittal plane deformity, and it's pretty easy to treat a frontal plane or coronal plane deformity. But when you have these multiplanar deformities, as you see here, patients walking on the outside of their fibula, very, very challenging to treat. And you have to think in 3 dimensions, which is very interesting because, an X-ray is 2-dimensional. So in a lot of these patients, I believe that we need some type of advanced imaging like a CAT scan or an MRI that allows us to look at the imaging in 3 dimensions. So the goal of deformity correction is really to restore the biomechanics. And you look at the foot on the film on the left, and you see the right foot of the patient looks great, but look at the left foot. Look at how their heel is looking at you. They have a hindfoot varus, which you can see in the center part of this illustration. And if you look at the left foot on the center film, look at their callus on their calcaneus. They're even bearing weight on the back of their heel, not even on the bottom of their foot. And that results in this lateral column overload and this ulceration that you see on the right. Now, again, you can brace this, and this patient was braced for a long time, but the recurrence rate is going to be so high in this particular patient. And so these are the x-rays of this patient that I've mapped out. And on your left, you see a son of a half moon. That's where the talus is. The talus is embedded in a Charcot deformity. And as a result, the talus first metatarsal angle, which should be 0 or 180 degrees if you'd like, is minus 20 degrees. If you look at the center film, the talus first metatarsal angle is minus 18 degrees. The patient's not even bearing weight on their medial column. It's up in the air, manifested by that dotted line. And then finally, what we call the hindfoot alignment view, there's a 36-degree varus deformity. So that calcaneus is pointing in a different direction. So again, when I think of this patient, when they presented to me, I'm thinking, how do I restore their biomechanics and correct this deformity so that I can get that ulcer to heal? And so if you look at the X-ray and look at the patient, it absolutely correlates where their problem is. They're overloading the lateral column near the base of the fifth metatarsal in the cuboid, walking on skin that's not meant to be walked on. So this is how I approach it. I do a deformity correction. And again, on the left, you see the pre-X-ray. And on the right, you see my post-correction X-ray. My talus first metatarsal angle is now 0. So I've corrected it in that one plane. When you look at the lateral X-ray, you can see that we've corrected it in the sagittal plane as well. And we've also corrected it in the rotational plane, and you can see that manifest a little bit differently. But the point is, now we've restored the biomechanics, we've allowed this patient to have an arch, and they're no longer going to walk on skin that is meant to be not walked on. And so this is the preoperative photograph on your left, and you can see that heel pointing out to you. And you look at the postoperative on the right, it's what we call a plantigrade foot. They're no longer walking on the side of their foot. And again, this is looking at it from the back. So in this particular patient, they went on to heal their ulcer. They have a foot that's actually able to be worn in a shoe. And so, you know, we were excited because we were able to restore the biomechanics. And this is just an illustration. I hope it works. But her walking, and this is only about 20 weeks post-op that she healed everything and she's walking well. And you can see she's actually in shoes, no longer in a brace. She has a little bit of a limp, which is not surprising. I want to go next to an ankle deformity. And this is a patient that I treated probably 7 or 8 years ago, type 2 diabetes for a long time, noticed pain and swelling doing some yard work, complained of warmth, erythema, and redness in his foot, went to see his primary care physician, and his physician reassured him after taking x-rays, and I'll show you the x-rays, and he continued to ambulate. These are his x-rays, and you know, they're not the greatest quality of x-rays, but they're sometimes what we get. And there's a subtle finding in here, which I'll show you in a little bit, but he was reassured that this was normal, and he continued to walk on it. So he then came to see me about a year later, and as you might expect, he had some problems. He had absent pedal pulses, he had edema, no wounds, fortunately. He had profound neuropathy, and on examination of his foot, he had a very significant malalignment, limited motion, what I call a non-plantigrade foot. He had no tenderness, he no longer was warm, and he no longer had erythema. But if you look at his foot, he went from having a relatively aligned foot to a foot that's at about 90-degree angles, and now he's walking on the medial ankle as opposed to the other ones. And you can see on the right, if you look at the fibula, he has a pathologic stress fracture of his fibula because this is the way he's been walking. Now, I don't need to have to tell anybody on this audience that when you have neuropathy and peripheral artery disease, this is a disaster waiting to happen. I don't know how anybody could put this into a shoe or a brace. So you look at the initial x-ray on your left, and you look at 1 year later when he came to me, and the subtle thing that I saw when looking at is a little bit of a talar tilt. Actually, and you see this, and most people wouldn't have appreciated that, but clearly this is the beginning. So at the time, he really had either a Charcot stage 0 or an early Charcot stage 1 that was not appreciated. And because of his neuropathy, he was allowed to progress to what you see on the right. His A1C was about 7.5%. His albumin was low. Vitamin D was borderline low. He had some chronic renal disease. But the interesting is he had a stress test and he was ischemic. And because they knew that I wanted to do surgery, they chose to put in a bare metal stent so he didn't need to be anticoagulated. Otherwise, I would have had to wait for 6 to 12 months. And I didn't think we had that time. So that was my initial assessment. And I felt that overall he had difficulty with ambulation. He had coronary disease and cardiomyopathy. He had peripheral neuropathy. He also had a 55-year pack-year smoking history, PAD. You can see his toe pressures were good, indicating healing, but still they weren't normal. He had a non-plantigrade foot. And this is a gentleman who has coronary disease. And if you want him to exercise, I don't know how you can get him to exercise except using an upper body machine, because he can't do anything with his foot. So my feeling was we had to intervene in this gentleman. So this is his x-ray. And one of the things that I've done as a part of my realignment is I've actually taken his talus out and realigned things. And I've learned this when I did pediatric orthopedics in a condition called arthrogryposis, because my goal is to put the calcaneus underneath the
Very
tibia.
good. I was going to get Chris to we got to get on a call with the minister today. You got to show up so that they know you're visible. Okay. So Salma sent you an email
Miriam,
with a Zoom link.
Miriam, you're not on mute.
Oh, I'm sorry. Anyway, so the calcaneus, in my opinion, we have to bring underneath the tibia. And the best way that I can do that is to take the talus out, and then I try and implant it back again. And so this is the talus on the back table. We then cut it, we prepare it, we machine it a little bit, and then we reimplant it. And in this case, this was probably 7 or 8 years ago, I used a short intramedullary nail to fix it. And so if you think about this gentleman, his host, 55-year pack-year smoking history, cardiomyopathy, peripheral neuropathy, coronary disease, renal disease. And so I saw him 2.5 years later, and he was lined up very, very nicely, and he'd lived, which is, you know, I think all these patients have problems with mortality, but we were able to realign him and get him a foot that he could actually put a shoe in. And so this was a big success for us, and we were pretty excited about this. And obviously he was a sick guy. So the simple clues to comorbidity, you know, for all of us, in my opinion, and this is what I teach my trainees, is that if a patient has a fracture like you see here and they walked on it, you don't have to be a neurologist to know that they have neuropathy. Is there associated retinopathy or nephropathy indicating some small vessel disease? Do they have numbness and tingling consistent with neuropathy or even painful neuropathy at nighttime? Do they have symptoms of claudication? And certainly it's sometimes these patients also have neurogenic claudication with bad spines. So we have to distinguish vascular from neurogenic claudication. And one of the big clues, if you see somebody that's lost a toe in diabetes, pretty good evidence that they've had an infection and probably neuropathy. Absence of hair growth is another good sign that I see with the shiny skin. And classically, the absence of pain or tenderness with an associated deformity. So we know about complicated diabetes because we've studied this, and this is what these patients are. And our patients surgically have higher complication rates. And why? Because they get higher surgical site infections. They impaired wound healing. They get non-unions of our fusions and even malunions, and hardware will fail. And so why is the complication rate higher in this cohort of patients? Well, I think neuropathy is really the evil element. You combine that with somebody who has poor glycemic control, who has impaired bone quality, either from osteoporosis or secondary hyperparathyroidism from renal disease, and you put some peripheral artery disease together, and you really have the perfect storm for developing complications. And so one of the most important things that I've learned over time is to treat every fracture or dislocation, or for that matter, sprain or strain in a patient with diabetes and neuropathy as if they have stage 0 Charcot. This is a case on your left where a patient came in with some very subtle widening of the plantar aspect of the first metatarsal, was treated for 12 weeks in a total contact cast by a very experienced diabetic foot expert, and then came to see me. And you can see, despite that, still developed a full-blown Charcot deformity that ended up progressing, and ultimately we had to treat with surgery. So I want to present one final case as a part of this, and it's really to beware of neuropathic ankle fractures in patients with diabetes. Those of us that are ankle surgeons We see this type of fracture every day in our practice. But when you see it in a patient with diabetes, you have to be very concerned about this. And so intraoperatively, we did a number of things. We doubled the hardware. We put a pin up the heel, and we left the operating room feeling very, very good about this particular patient. We lined the ankle up. We were patting ourselves on the back and, you know, giving high fives to everybody. And we're pretty excited. But within 2 weeks, this patient fell at home, called our office and said she felt a pop. And so her lateral incision looked great, but her medial incision had completely dehisced, and you can see one of the screws coming out through the medial incision. And unbelievably so, this is what happened, that her hardware completely disrupted in 2 weeks. She broke the plate, her ankle dislocated, and now essentially she had an open injury to the ankle joint. So just 2 weeks before, we were celebrating how proud we were, and now we were very depressed about this. So we took everything out at this point, put the patient in a multiplanar external fixation, realigned things. We were happy and ultimately got the wound to heal and got some stability. We never got it to heal completely, the bone, but we thought that this was lined up satisfactorily. We could put the patient in the total contact cast, which we did. But eventually, 1 year later, developed some lateral wounds now. And you can see that further deformity developed. Now she was going from having a medial wound to having a varus deformity and having a lateral wound. And ultimately, tragically, this is what happened. We did a staged transtibial amputation in a patient. And so when you see patients with diabetes and neuropathy who experience an ankle fracture, far too commonly, this scenario happens. It's estimated that about 1 in 5 patients with bad neuroarthropathy can develop this so that they end up with an amputation. So it's a very challenging thing to treat. So my take-home message for everybody on this webinar is that we as surgeons are not born with wisdom. We finish our training with a lot of knowledge, but we become wise only through failure, as I showed you in this particular case, because we beat ourselves up, and I think that failure is our best teacher. We have to grow from each failure and teach ourselves so that we can help the next patient. As surgeons, we're rarely satisfied. We're always striving for better results. And we're lifelong learners. And we want to innovate and continue to improve and refine our techniques. The techniques that I use to reconstruct a Charcot deformity are different today than they were 5 years ago. I've learned some things from Venu, going and attending his courses and teaching with him, that I've adopted as well. So I've yet to do my perfect operation. And remember that knowledge without wisdom can only take you so far. That's enough. That's what I'll have for the presentation, Vijay, and be happy afterwards to take questions.
Thank you, Dane. I think you can